Welcome to the lecture on the axilla and the brachial plexus. My name is Suarez-Quian, and I will narrate the lecture for you. Let's begin. There are three objectives in this lecture. First, I will define the axilla, in particular its boundaries. Second, I will describe the brachial plexus, specifically the different components that make up the plexus and its terminal branches. And third, based on the normal innervation patterns of the terminal nerves of the plexus, I will describe some lesions of these nerves and explain the pathognomonic sign of a particular nerve lesion. Here we see an individual apparently quite proud of his axillary region. The term axilla in Latin stands for the armpit, and that is the region that we're about to describe in this person. In an anterior view of the axillary region, the axilla is demonstrated to be a pyramidal-shaped structure that extends from the skin of the axilla to just behind the clavicle. In fact, the base of the pyramid is precisely where you put your hand if you were to put it in your own axilla. Try and realize that the axilla is actually a large area between the upper part of the arm, the chest wall, and the clavicle and the scapula. One good way to understand the boundaries of the axilla is to look at it in an axial or horizontal section, as shown in the image. Now outlined in red is the pyramidal-shaped region of the axilla. And now it is clear that this region is characterized by certain boundaries. The anterior wall of the axilla consists of the pectoralis major and minor muscles. The posterior wall consists of the teres major, latissimus dorsi, and subscapularis muscles, and the scapula itself. The medial wall contains the serratus anterior muscle and the corresponding ribs, whereas the lateral wall is rather narrow and made up of the intertubercular groove or sulcus of the humerus between the greater and lesser tubercles. So now, when you think of the axilla, you will be able to recognize the surface projections of the muscles that help make up its boundary. For example, as shown in the image, the contours of the anterior and posterior boundaries are clearly visible. The pectoralis major and the latissimus dorsi muscles make up these boundaries, respectively. Another way to appreciate the region of the axilla is to view it in a coronal section, as shown in the image. The area of the axilla is now indicated in red, and the boundaries are labeled in the image. Showing the boundaries of the axilla, however, does not indicate that one should memorize its boundaries as a list. The description provided is simply to indicate to students the general locations of this important area of the body. What the image does make clear, however, is that the major content of the axilla is fat. Indeed, for those that have dissected an axilla, it is not uncommon to extract a few cups of fat even from a relatively thin individual. This is normal. The fat is there to act as a dampening buffer for the other important structures present in the axilla, the brachial plexus and the axillary artery and its corresponding veins. Now that we know the area of the axilla, let's describe the brachial plexus. The brachial plexus is formed in the posterior triangle of the neck. It is formed by the union of the anterior rami of cervical nerves 5 to 8 in T1. The brachial plexus supplies the skin and the musculature of the upper limb. The brachial plexus also supplies all the muscles of the upper limb originating from the chest wall and the back, except for the trapezius muscle. If you have studied the back prior to this lecture, you know by now that the trapezius muscle is innervated by cranial nerve 11, the spinal accessory nerve. Having mentioned the posterior triangle of the neck as the area where the brachial plexus originates, let me define this area for you. Anatomists define the neck into two main regions: the anterior triangle, now shown in red in the image, and the posterior triangle. The boundaries of the anterior triangle are generally described when we study the head and neck region and do not concern us at this time. But let's focus on the boundaries of the posterior triangle, which does concern us at this time. The anterior border of the triangle is the posterior border of the sternocleidomastoid muscle. This muscle is prominent in our necks, easy to palpate, and is used to turn our heads to the contralateral side of the muscle. The posterior border of the triangle is the anterior surface of the trapezius muscle. As discussed previously, we use this muscle to shrug our shoulders. The base of the triangle is actually the clavicle. However, I'm indicating the actual portion of the posterior triangle of the neck where the brachial plexus is found. As before, it is not necessary to memorize the details of what makes a boundary, but students should make an effort to know what is meant by the posterior triangle and at least should be able to point it out on a physical examination of a patient. And here's an actual drawing of a dissection made by Grant indicating the posterior triangle of the neck containing the origins of the brachial plexus. The image shows the roots of the brachial plexus emerging in between two muscles, the scalenes, by way of the scalene triangle. The clavicle was removed to demonstrate a better view of the posterior triangle. This image is again for orientation purposes. The posterior triangle of the neck is studied when students examine the head and neck anatomy. I stated earlier that the brachial plexus originates from the roots of C5 to T1. Some authors even describe a small contribution from C4. The term roots is somewhat misleading here, but let me review what is meant by the origin of a root, or more precisely, a ramus, and in a short while I will describe why the term root remains in use for historical purposes. Located on the dorsal side of the spinal cord is the dorsal root. Afferent fibers from the periphery are present in this root. Emerging from the ventral side of the spinal cord is the ventral root. Efferent fibers are present in this root. The dorsal and ventral roots combine as a short spinal nerve and exit via an intervertebral foramen. The spinal nerve splits almost immediately into a dorsal ramus and a ventral ramus. These rami, plural for ramus, carry both motor and sensory fibers. It is the ventral rami that form the brachial plexus, and this is what makes it confusing in terms of terminology. A spinal nerve is formed by roots and gives off rami, Latin for roots. But try to understand that roots and rami are functionally different. So now that we reviewed what is a rami and where the brachial plexus is located, we can investigate where the different components of the brachial plexus are found. In brief, the roots, the trunks, and divisions are all located in the posterior triangle of the neck. This is shown by the purple, green, and yellow areas in the upper figure. Cords, however, based on the definition of the axilla, are found in the axilla, as are the terminal branches of the cords. Students often ask how this cumbersome terminology came to be. The answer goes back to the Renaissance, when some of the first anatomists were looking for similarities between their dissections and what they observed in nature. The brachial plexus appeared to some as resembling the components of a tree. That is, roots give rise to trunks, trunks split into divisions, divisions combine into smaller cordwood, ideal for splitting into firewood, and the cords ultimately end as branches, the terminal nerves. All in all, the naming of the different components of the brachial plexus does make some sense. As its name implies, a plexus, from the Latin for braid, is a branching network of vessels or nerves. Some plexuses are difficult to dissect, but not the brachial plexus, and by understanding its composition, it is possible to discern where lesions occurred in the plexus to help explain a patient's condition. There are many schemes now available in YouTube that help you draw the brachial plexus. Drawing the brachial plexus takes practice and repetition. The exercise is usually rewarded at test time, but more importantly, in the clinic. Let me now show you how the brachial plexus takes its form. The common ventral roots that make up the brachial plexus, C5 to T1, are now indicated by the blue arrows. The upper two roots come together to form the upper trunk. C7 continues by itself and gives rise to the middle trunk. And the lower two roots, C8 and T1, combine to form the lower trunk. The next event that takes place is that all trunks will give rise to anterior and posterior divisions. Shown in the image are the three posterior divisions from the three trunks that ultimately come together to form the posterior cord. Let's now take a look at what happens to the anterior divisions. The anterior divisions of the upper and middle cord join together to form the lateral cord. Meanwhile, the anterior division of the lower trunk continues by itself to form the medial cord. Now we're ready to identify the terminal nerves that emerge from the brachial plexus. From the upper three roots, C5 to C7, the long thoracic nerve will form and travel to the serratus anterior. From root C5, the dorsal scapular nerve emerges to innervate the rhomboids and levator scapulae muscles. From the upper trunk, the suprascapular nerve emerges and travels to the supraspinatus and infraspinatus muscles of the scapula. A small nerve, the nerve to the subclavius, also emerges from the upper trunk. From the lateral cord, we see the exit of the lateral pectoral nerve. This now makes clear why the lateral pectoral nerve is so called, because it emerges from the lateral cord, not because its topographical relationship to the medial pectoral nerve when first observed in a dissection of the pectoralis major muscle. And now labeled is the medial pectoral nerve emerging from the medial cord. So far so good, but now it may get a bit tricky. Let's look at the terminal branches of the posterior cord. Most proximal is the upper subscapular nerve to the subscapularis muscle. Distal to it is the thoracodorsal nerve to the latissimus dorsi. and then the lower subscapular nerve that goes to the subscapularis and teres major muscles. The posterior cord terminates as the axillary nerve that enters the quadrangular space and innervates the deltoid and teres minor muscles, and the radial nerve that will serve the muscles found in the posterior compartments of the arm and forearm. Looking at the lateral cord, we see that it terminates at the lateral root of the median nerve and the musculocutaneous nerve that innervates the muscles located in the anterior compartment of the arm. We look next at the terminal branches of the medial cord, the medial root of the median nerve, and the ulnar nerve. The lateral and medial roots come together to form the median nerve that will innervate most of the muscles of the forearm and the thenar eminence. The last two nerves left to identify are the medial antebrachial cutaneous nerve to the forearm and the medial brachial cutaneous nerve of the arm. Now, all the terminal nerves of the brachial plexus, as well as the proximal components of the plexus, are fully labeled. What I've not made clear up to now is what is the reference point for labeling the cords as lateral, medial, and posterior cords. Their naming is based on their respective relationships to the axillary artery. Let's look at this relationship that is shown in the image. A longitudinal image of the axillary artery and the cords is shown in the bottom image, whereas the top image demonstrates the relationship of the cords to the artery in an axial section. The axillary artery and vein, red and blue respectively, are now labeled in the cross section. And the relationship of the lateral cord to the vessel is now indicated. The medial cord is now labeled. And finally, the posterior cord is labeled. As stated earlier, the nomenclature of the cords is completely based on their relationships to the axillary artery. Having shown the anatomical basis of the brachial plexus, let's look at some examples of where the terminal nerves travel to innervate the muscles of the upper limb. After emerging as a terminal branch of the lateral cord, the musculocutaneous nerve travels to the anterior compartment of the arm to innervate the flexor compartment of the arm. The median nerve travels from the brachial plexus to the forearm and innervates most of the muscles of the flexor compartment of the forearm. The ulnar nerve was one of the terminal branches of the medial cord and travels to the forearm where it innervates 1.5 muscles, then continues to the hand. The radial nerve, one of the terminal branches of the posterior cord, travels to the posterior compartments of the arm and forearm to innervate the extensor muscles. Let's look now at some classic pathognomonic signs following injuries to the brachial plexus. A pathognomonic sign or symptom is a specific characteristic or indication of a particular disease or condition. Classic pathognomonic signs are rare, but in lesions of the upper limb, they tend to be quite clear, as I will now demonstrate. A winged scapula is specifically a sign of damage or paralysis of the serratus anterior muscle. The medial border of the scapula moves away from the thoracic wall when pressing against a wall, as shown in the image. The upper limb cannot be abducted above 90 degrees because the scapula cannot rotate. Injuries to the long thoracic nerve occur when limbs are raised, as in fights, and the long thoracic nerve is cut. If the axillary nerve is injured, the upper limb of the affected side cannot be abducted to the horizontal. Injury to the nerve can occur in fractures of the cervical neck of the humerus or shoulder dislocations. The injury results in the inability to abduct the limb, wasting of the shoulder contour, and an area of anesthesia of the shoulder. The thoracodorsal nerve is at risk of injury during axillary lymph node dissections. This is because it lies anterior to the axillary artery and axillary lymph nodes. In breast cancer surgeries, it is common practice to also remove axillary lymph nodes to determine if the cancer has spread to the nodes. The nerve is at risk during these procedures, although most surgeons today tend to isolate the nerve and secure it before continuing to the axillary lymph node dissection. If the nerve is cut, however, paralysis of the latissimus dorsi muscle ensues. Persons so afflicted will be unable to raise the trunk, as occurs while pulling oneself up by the arm. This action is what extension of the humerus by the latissimus dorsi muscle entails. Also, a person will not be able to use an axillary crutch because the shoulder is pushed superiorly by it. When using crutches, it is recommended that one not rest the axilla on the crutch. This will ultimately compress and damage the brachial plexus. Proper technique entails the use of the latissimus dorsi muscle to help support the weight of the trunk on the crutch. Clearly, this is not possible if the thoracodorsal nerve is cut. A well-known lesion of the brachial plexus is known as Duchenne-Erb palsy. It occurs following trauma, as shown in the left hand of the image, when there is excessive separation of the shoulder and neck. A similar injury can ensue from a difficult delivery. Again, when forcefully pulling out the baby, it is possible to excessively separate the head and neck from the shoulder and damage the upper roots of the brachial plexus. If permanent damage to C5 and C6 roots occurs, the upper limb will be left in what is described as a waiter's tip position. The limb hangs by the side in medial rotation and partial extension. This is shown in the middle image by the left upper limb. Let's look again at the brachial plexus and determine how this waiter's tip configuration comes about from an injury to C5 and C6. The brachial plexus is again shown in the image, and all terminal nerves emerging from it are labeled. The nerves that receive contributions from the C5-C6 roots are now labeled in red. Indeed, it seems that many of the nerves receive some contribution from C5-C6, and that this lesion is quite severe. To discern precisely what is happening after the lesion, let's start by crossing out the contribution to the brachial plexus by the C5-C6 roots. And now shown is the path that the C5 root takes in sending nerve fibers to its terminal branches. We can perform the same exercise for the C6 root, and having done this, we can now more precisely discern which terminal nerves will truly lose all input from the motor components of C5 and C6. Looking again at the brachial plexus, we'll see that the dorsal scapular nerve will be completely devoid of motor fibers if the C5-C6 roots are injured. This is indicated by the red box and an asterisk. Hence, the action of the rhomboids and levator scapulae are eliminated. In this situation, one would expect the scapula would not be able to be retracted and or elevated. However, remember that there are redundant muscles capable of performing these actions. For example, retraction of the scapula can be accomplished by the serratus anterior and trapezius muscles. Elevation of the scapula can also be performed by the trapezius. Thus, while these actions are impaired, they're not abolished. The suprascapular nerve also is totally wiped out. Thus, the supraspinatus and infraspinatus actions are eliminated. The lesion to the supraspinatus is a key sign that the upper roots are injured. The supraspinatus initiates upper limb abduction. In the absence of this muscle, the limb will hang to the side of the body as demonstrated in the image. The lesion to the musculocutaneous nerve is also key in figuring out what is happening after lesion of C5 and C6. This nerve is responsible for the anterior compartment of the arm muscles. These muscles help flex the shoulder and elbow joint, but importantly, the biceps brachii is the major supinator of the radial ulnar joint. Loss of the musculocutaneous now leads to the radial ulnar joint presenting in the pronated position due to the unopposed action of the pronator muscles. These muscles are innervated by the median nerve, which, as shown in the image, is not impacted by lesions to C5 and C6. And finally, the radial nerve is also moderately impacted by a C5-C6 lesion. However, relative to the effects of losing the musculocutaneous nerve, one can see that the C7 to T1 roots contributing to the radial nerve remain intact. Thus, in balance, the upper limb could present with some slight extension in a C5-C6 lesion. To summarize, I have prepared this table of the nerves that will be most impacted by a C5-C6 lesion, the muscles that will be affected, and the impaired action of the upper limb that will be limited following the lesion. You can stop the video to review this table. Based on the information presented in the chart with respect to which muscles are impaired, we can present a general scheme of what actions of the upper limb will be limiting in a C5-C6 lesion. For example, abduction of the arm will be completely eliminated. Flexion of the forearm will also be completely eliminated. Supination of the forearm will also be completely eliminated. Extension of the arm may be impaired, but not necessarily eliminated. Further, even if a patient is unconscious, the physician can surmise the level of the lesion by testing for tendon reflexes at the appropriate locations. And finally, now that we have discussed what is meant by Duchenne-Erb palsy, let's look again at the patient and remind ourselves how they should present. Since the shoulder abductors are eliminated, the upper limb is adducted by way of the unopposed adductors of the upper limb. Since the forearm flexors are eliminated, the forearm is hanging down, but not necessarily extended. Gravity has much to do with this. Finally, the forearm is pronated because the main supinator, the biceps brachii, is now not functioning. Let's now repeat the same exercise we did for a C5-C6 lesion, but look at a lesion of the inferior part of the brachial plexus. These lesions are much more infrequent and occur when the upper limb is suddenly pulled superiorly as indicated in the image of the man hanging on a tree, or a child being born and the clinician pulling on a limb. The pathognomonic sign for these types of lesions is said that the hand resembles a clawed hand. We start again by looking at the brachial plexus and injure the C8, T1 roots. Branches from C8 travel to the medial cord by way of the lower trunk and anterior division of the lower trunk, and to the posterior cord by way of the posterior division of the lower trunk. Branches from T1 follow the same pathway and end up in the medial and posterior cords. As before, let's highlight the terminal nerves that will be most impacted following a C8-T1 lesion. First, we see that the medial pectoral nerves and the medial brachial and antebrachial cutaneous nerves will be affected. However, since the lateral pectoral nerve remains intact, it is not a major event to lose the function of the medial pectoral nerve. Since the medial brachial and antebrachial nerves are simply cutaneous, their loss will not be noticed as a skeletal muscle deficit, simply loss of sensation. But now we see that the ulnar nerve consists exclusively of C8 and T1 branches. Hence, such a lesion will have tremendous impact on the muscles controlled by this nerve, that is, the muscles of the hand. As before, I've created a table of the principal nerves that will be affected following a C8-T1 lesion. The main loss of muscle action noted are hand muscles, and of these, the action that is most obvious is that of finger abduction and adduction. This can be easily demonstrated in an individual by asking them to hold a credit card in their outstretched fingers. They cannot do it. The loss of C8 and T1 can be summarized by stating that loss of C8 leads to inability to flex the fingers at the metacarpal phalangeal joint and action of the interossei muscles. The loss will be greater for the ulnar side of the hand than the radial side. The first two lumbricals can partially flex the metacarpal phalangeal joint since they are innervated by the median nerve and will not be affected. Also, the ability to abduct and adduct the fingers is completely eliminated. The lesion can be confirmed in unconscious patients by performing appropriate tendon reflexes. You will learn about these in physical diagnosis. And now we can appreciate why the C8-T1 lesion is said to result in a clawed hand. The hand is mostly left immobile, the fingers cannot adduct, abduct, and flexion of the MP joint becomes difficult, if not altogether abolished. All fine movement of the fingers is lost. The hand becomes a claw rather than a fine device for enacting the pincer-like action for which it is known. One last injury that we need to consider is that of the radial nerve. It results in one of the most easily recognized pathognomonic signs of brachial plexus injuries: wrist drop. The radial nerve can be injured along its path to the back of the forearm. All the extensors of the wrist can be affected if the nerve is injured proximal to where the nerves to the extensor muscle bellies are supplied. The unopposed action of the flexors following damage to the radial nerve and loss of wrist extensors explains a pathognomonic sign of the wrist drop. This now concludes the lecture on the axilla and the brachial plexus.